Hope everyone is well. We're going to try and cover a lot of information here. This is not a simple subject. I'm going to try and condense it and hit the high points. What we're trying to do is to review the risk adjustment coding and the differences between the HS version versus the CMS version. The HHS version is, of course, the Health and Human Services version. And the CMS version is used for Medicare Advantage. The bottom line is the diagnosis you code are basically the same. The calculation, the risk score is a bit different, but I'm going to point out those differences. I'm going to be using mainly the Platinum 2022 HHS risk scores for comparison. I'll explain what that is in a couple minutes. Commercial payers do use these for their value-based models as well. So again, there's a lot of things that we have to cover here, and I'll try and go over them in detail so that you have a better understanding of them. These are examples, and the information provided are not a substitute for specific clinical judgment by the provider, and they can vary for each individual patient that is evaluated. So the goal is that providers need to include all diagnosis codes with the appropriate documentation and high specificity for every medical condition that is either evaluated or influences their treatment decision at the time of the office visit. Just want to show this. This is over the whole continuum from neonatal through Medicare. A lot of you will see different population breakdowns for just the Medicare population, where a smaller percentage of the population, maybe the top 5%, makes up 75%, but this is over the entire healthcare spending prior to COVID in 2019. Again, what I want to demonstrate here is that age groups, as you get older, of course, we're going to see a higher proportion of that spending. We can see that with the Medicare population here at 17%, but 35% of the spending. For the age group of the 45 to 54, we see that 13% of that, they make up 13% of the population and 13% of the cost. And then as we go down from there, we'll see the 19 to 34, 21% of the population, only 12% of the cost. And of course, the pediatric population, 0 to 18, makes up 25 or 24% and accounts for about 9% of the spending. In pediatrics, of course, most of the spending is in the neonatal inpatient setting, and I'll show you that in a couple of minutes too. For the pediatricians, these are the breakdowns of spending, the different categories, the newborn, the ADHD, asthma, well child. Again, these you can review at your own leisure, but just to give you an idea. And then for those of you that want to understand the different cost centers by the age group, I've included this slide to show the different cost centers from hospice, nursing, prescription drugs, by age group as well. So the big thing is the terminology here. HCC, of course, is the hierarchy of condition categories. These are the chronic conditions that are used to create the risk adjustment methodology. The differences here is CMS uses the HCC for MA patients. HHS uses it to pay the marketplace plans, and then some commercial plans use this, such as Blue Cross here in North Carolina. The rafhhscoding that's just for drugs. Drugs do adjust differently. In CMS, it's only for medical expenses. And then, of course, RAF stands for risk adjustment factor, which we'll define here again, too. So why did they develop these? Well, they had to pay Medicare organizations differently based on the disease burden. So they had to create these categories, and their categories are assigned a risk factor. And then there's a hierarchy weighting, which assigns higher values to more serious conditions. But you can only have one condition in the same category. The big thing is every year you have to enter these again. So what they did is we've got 72,184 ICD-10. This changes every year, of course. Right now we have just under 10,000 or 9,757 that map to an HCC category. You have to map to an HCC category to get a risk score. Otherwise, so we've got 60-some thousand here, 62,000 codes that do not RAF or do not give you a risk adjustment. So the big difference here is that CMS uses this to pay MA plans, HHS uses this to pay the marketplace insurers, and then some commercial players like Blue Cross use these for value contracts. CMS is only using it to predict medical expenses, not drug expenses. It's a prospective model which uses last year's cost to predict this year's cost, and the HSS model predicts both medical and drug spending and includes categories for infants, children, and all age adults, including obstetrical diagnosis codes. HHS is a concurrent model. It uses this year's diagnosis to predict this year's cost. So make sure we understand that. CMS model, prospective. It's using data from 2021 to predict 2022 expenses. HHS is using a concurrent model which uses expenditures from 2022 to predict the cost for 2022. Again, the HSS model has multiple age group models, but the big thing is it uses this terminology, which I'm going to define here, platinum, gold, silver, and bronze, which is for the marketplace. And what does that mean? Well, there's 4 different plans they offer on the marketplace. Bronze, where you're going to have the lowest premium, but you're going to pay the highest deductible, and then platinum, where you're going to pay the highest premium and no deductible. So what that means is that HSS is going to assign a risk score different for each one of these. The higher the plan here, the higher the premium, then the higher the risk score is going to be, because the insurer or the payer is going to pay more of the premium. So you're going to see a huge difference between a platinum risk score, not huge, but a significant difference between a platinum and a bronze level risk score. For the purposes of this discussion, I'm just going to use the platinum scores so you can use for comparison. The percent of patients with HSS diagnosis, adults, 80% have no HHS diagnosis code. Only 15% have one, and 5% have 2 or more. In the children, it's 91% have 0, 8% have 1, and 2%, 1% have 2 or more. And then the infant, of course, we have 55% have none, 1 diagnosis codes, and 39% and 6% have 2 or more. This just shows the differences in the programs in the top 10 diagnoses. Of course, in the 65 and older, you expect the more chronic diseases, diabetes with complications, without complications, COPD, heart arrhythmia, CHF, vascular disease. This is the adult in the 18 to 64 range. Of course, we see diabetes still there, but now we've got depression, asthma, diabetes with chronic complications. We've got cancer that moves up a bit. And then if you compare the two between the pediatric HHS and the adult HHS, you're going to see, of course, less of the chronic type disease. You're going to see asthma, depression, seizure. You are seeing diabetes, autistic. So there's a big difference in the age group models here. So again, the diagnoses for the most part are the same, but there's different ones in the HS model. They include things from cleft lips to Down syndrome, pregnancy, things that we don't see in the Medicare population. And here's an example of the HCC categories in the HHS model. We're seeing pregnancy and things like that we don't see in the CMS model. So the big difference is HHS is intended for all patients. It predicts future medical and drug spending. It's concurrent, using the data from the current benefit year to predict current costs for the same year. And it's got 3 different models: the child model, 2 to 20, the infant model, 0 to 1, and the adult model. So I said hierarchical conditions, they're arranged so the more severe diseases have a lower number in the HCC category, meaning that, let's look at metastatic cancer here. 8 is going to be lower than 9, 10, 11, 12. So if you have any of these cancers, lung cancer, colorectal, breast, prostate, if you have metastases, this code, anything that metastasizes, codes into the HCC 8, which means the only risk score your patient is going to get credit for is category 8, and it's risk adjusted. So the 9, 10, 11, and 12 no longer are added to it. So basically, if you have and diabetes, the same thing. Diabetes, the acute complications are going to trump the chronic complications. We're going to trump the without complications. But I'll show you in the HSS model why that doesn't matter as much. But basically, any of these codes, so the lower that HCC category, that's the one that's going to trump the one that's above it. So 28, we're going to trump 29 for cirrhosis of the liver. Schizophrenia is going to trump 58, which is another psychosis. So again, I just included these, but to show you an example here, the RAF under the HCC model is 2.66 for any of these cancers, where it's 22.9 for anything that's metastasized. And again, remember, in the HHS model, we have younger populations. Complications of diabetes don't really manifest themselves as extra costs for the most part. So in that model, everybody gets the same RAF score. But you always want to code to the highest specificity. And again, if you see the differences here in the CMS model, if you're not coding those complications, you're going to get a third of the risk score. So it's important, always code any complications or any other associated symptoms with a diagnosis. So risk adjustment factor, well, the average for the patients are 1. Every year this is readjusted, so it goes to 1. Healthy patients have a below average, less than 1. Sicker patients have an above average, it's greater than 1. There are no negative RAFs. Again, the RAF is used as the mechanism to differentiate resource consumption. A healthy person who rarely sees versus a person with multiple comorbidities. Everybody gets an age and sex risk score. So everybody has a positive score. If you have health conditions such as diabetes, congestive heart failure, things like that, then those are added to the risk score. Same thing in the HSS model. They use the age and sex demographics. They use the risk factors for the diagnoses, the diabetes, depression, asthma, things like that. And then they have this disease interaction risk factor, which is much different than the CMS model, and I'll show you in a minute. The infants, there, it's very important to, and I'll show you an example of this, that we code these based on birth weight and gestation for prematurity. They also get the age and sex. The male gets an additive term, of course, circumcision, some other things the male is going to have in the early years that the female may not. So this shows the different risk scores for the different categories. Again, each category by age has a different, and sex has a different risk score. Each of the HCC has a different weight. So if you have HIV, you're going to get the 1.5 for the platinum risk score. Now, again, this is kind of a busy slide, but I included a lot of things for the pediatricians because, again, they all get risk factors for the age 2 and above through age 20 for male and female. But it's the infants where most of the cost is, and this is where the most of the breakdown. There's 25 different categories. There are 5 categories of immaturity, from extremely to immature to premature to term to age 1 or to age 1. And then there's 5 levels of severity with other diagnosis codes. So let me show you again, just a reminder that the HHS has things like pregnancy and things like that that aren't in the CMS model. The higher the risk score, the greater the average burden of illness. The lower the risk score means they're either healthy or you didn't code them all the diagnosis codes. And I do want to make this point that every year this changes. So if you look at the 2022 coefficients for diabetes, they're 2.6, where they were 2.8 in 2021. The reason being, we have to zero everybody out to 1 each year, or average everybody out to 1 each year. So diabetes, increasing number of diagnosis codes. So the more people with diabetes, to keep that average at 1, you're going to have to lower the score. HSS, again, they give you the drug that CMS does not do with the traditional MA plan, and that I'll show you they do with Medicare Advantage, the Part D. But again, so any of your patients that are on HIV drugs or on insulin or on diabetes medicines, MS medicines, cystic fibrosis agents, they are going to get an additional prescription drug risk score added to their category. The disease interactions, very important. Any of your patients that would have septicemia, peritonitis, seizures, coma, pulmonary emboli, respiratory failure, respiratory arrest, respiratory dependence. If they have any of these conditions, all of these here on the right side, with any other category on the left side here, an opportunistic infection, lung brain cancer, pediatric ALL, non-Hodgkin's lymphoma, myelodysplasia, liver failure, neonatal hepatitis. If you have any one of these on the left, you're going to get the risk score for that. If you have any one of these on the right, you're going to also get the risk score for that. But if you have both, one from the right, one from the left, you're going to get an interaction which essentially equilibrates to about $30,000 additional dollars to that patient's medical cost. In CMS, they only really do things for the CMS model. They only do CHF and mainly diabetes, COPD, heart arrhythmias, renal disease. They do COPD and respiratory failure and cancer and disordered immunity. But again, very limited disease interactions. So back to the showing this, of course, the biggest spending per child is in the neonatal or the early less than 1, age 1. These are the codes you need to use if there is prematurity, because this is what's going to get the risk codes, the risk scores appropriately. You have to record the birth weight. You have to record the term. So the combination of this is going to determine your maturity level. Extremely immature, there's 5 categories: extremely immature, immature, premature, term, and age 1. So that's part of this determination. And then these diagnosis codes, if they have any of these diagnoses, peritonitis, heart transplant, congestive heart failure in that time period, that's going to get them a severity level. So each one of these 5 codes has 5 severity loads. That gives you 25 codes. And that's where you get into this extremely immature, severity level 5. And let me show you some other examples. These are some of the examples. There's a full list that you can find here, but these are some of the examples in the different severity levels that will code. This is just some examples of costs that are associated if you use this model for the marketplace. You know, hip fractures, $36,000, sickle cells, $9,000, asthma, $4,000, third-degree burn, $93,000. So again, just showing you some of those costs. So just to show you the big difference here, because again, don't get hung up on the values of these risk scores. It's the categories. They have similar categories, but HIV for AIDS in the HHS model is going to be 1.5. For the CMS model is 0.335. But then they multiply that by a certain dollar amount. This dollar amount is much higher for the risk score in CMS than it is for HSS. So that's why these things are different. And again, it's all relative. The biggest thing is if it's not documented in the medical record, then it did not happen. Again, the 2 major things that come out of audits are stroke and heart attack that are coded incorrectly. And providers, you now sign contracts that a lot of times will pass this risk on to you. If you're miscoding or you're not coding correctly, you can be held liable in some of these instances, or a group like your ACO for upcoding. So it's important that you document everything correctly. There's 3 points. You need to make sure it's a face-to-face visit. There is telemed now that is permitted for some of these. We're not sure how long that's going to last, but it's always best to do it in a face-to-face. You do not go back and document when they sent you a letter from the insurance company asking if the patient had this condition, and you go back and document. That's not considered appropriate. Status or condition: status stable. You've got worsening, labs or test ordered, medications adjusted. Those are kind of examples. Plan of action. So COPD, stable, continue current medicine. So you have to have at least those 3 points. But the critical thing you have to have is what they call the meat. You have to document that you've monitored the signs, symptoms of disease progression, disease regression. You've got to evaluate it, test results, medication effectiveness, response to treatment, assess and address ordering tests, discuss, review records, counseling, treatment, medications, therapies, other modalities. So you have to satisfy all 4 of these points. So remember, you have to evaluate each diagnosis. It's got to be face-to-face. Telemed will work acceptable for now. You cannot refer to a problem list as documentation. So simple things that can get you credit: diabetic with neuropathy, stable, meds adjusted; CHF, compensated, continue meds; COPD, PFT ordered, refer to pulmonary; hypertension, uncontrolled, add medication; hyperlipidemia, stable on meds. All those things will pass the meat test. You do not code non-definitive conditions: probable, possible, questionable, rule out. Those don't work. That is upcoding. The code, you always code to the highest degree of specificity, and make sure you include the signs, symptoms, and any other reasons for the visit and abnormal test results. So again, without the meat, you're guilty of deceit, which will land you in the payer's hot seat. Why is documentation and specificity so important? Well, let's look at hepatitis. Hepatitis C unspecified, you're going to get no RAF. It's not very specific. Hepatitis C that's acute, that's considered a self-limited disease, and that's not going to get you any RAF. Its hepatitis chronic, though, is going to get you a RAF score. This looks like you did a pretty good job of coding. Diabetes with diabetic retinopathy, macular edema, macular degeneration, congestive heart failure, obesity. You get a 0 RAF. Why? Because these diagnoses are not specific, and I'll show you why in a couple minutes. So the best practices: history of indicates condition no longer exists, so you do not use with chronic conditions you're currently treating. Instead, you use history of diabetes, patient with diabetes mellitus since 2009, well controlled on current meds, continue current treatment. Instead of CHF, meds Lasix, compensated CHF, stable on Lasix. Instead of COPD, meds Advair, COPD controlled with Advair. So you can link diseases. This does create a clear relationship to the diagnosis and does have some RAF implications. You always want to use due to, because of, related to. You do not want to use with unless it's diabetes. Diabetes, all the codes are with, but for the most part, do not use with when you're trying to link diagnosis causal relationship. You must include permanent conditions each year: transplant status, quadriplegia, dialysis, current ostomies, amputations, asymptomatic HIV infections. These things don't go away, but CMS gives them, you have to code them each year, and HSS, you have to code them each year. Just a simple, I want to make sure, because I brought this up, there is a RX RAF. This is mainly for Part D, but some commercial payers do use this, where patients do get a score based on their diagnosis. So they may get a 0 RAF, but they do RAF for this, and again, with the exception here of asthma, which I'm going to show you, these diagnoses don't really RAF for a score, but they do give a RAF medication, especially for the CMS version, and in some commercial versions they do too. So it's important to include these diagnoses when you are seeing patients. Again, just a review, we did include in the HHS the drugs. So for pediatricians, chronic condition is lasts over 3 months, affects the child's normal activities, and requires medical care and hospitalization. Approximately 15 to 18% of the children in the United States live with chronic health conditions. Some examples include asthma, diabetes, epilepsy, sickle cell anemia, congenital heart disorders, and cancer. Depression, very much overlooked when we review charts. A lot of the tendency to write off depression as being moody in preteen or teenager, but remember, suicide is the second leading cause of death between 10 to 34. Epilepsy, another one that there is some discrepancy as physicians tend to use criteria differently. The accepted criteria, this is a very prevalent, 450,000 children under the age 17. I showed you it's up there on the top 10 diagnoses. So one of some of the accepted for if the child has one or more seizures, believes that the child is likely to have another seizure, the seizure is not directly caused by another medical condition, it's usually coded as a seizure. Diabetes, as you saw, diabetes on the top of both of those lists, near the top one for the adults and higher up for the kids. Of course, there's going to be type 1 in kids. 90 to 95% of diabetes in the United States is type 2, but in children, of course, type 1, 100%. Is there a manifestation or complication? Always document this. Name the manifestation and state the manifestation is due to diabetes. You should always comment controlled or not controlled. Now, I want to show you this because, again, in the HHS model, because, again, these patients aren't very old, all of the diabetes codes, even without complications, code to the same HCC weight. That does not play into CMS, and that does not play into some of the commercial plans that even use the HHS. So it's always critical, even though they are giving you this score as equal. In many of the models that are used by commercial payers and in the CMS model, you get extra credit for using these extra RAF score for using these different manifestations: kidney disease, eye disease, neurologic neuropathy, peripheral vascular disease. And again, you're using the code with for this. So remember, diabetes, there's a lot of different things that can be manifested by diabetes, but if the medical record says only diabetes, then you have to use uncomplicated. In the CMS system, that RAF is going to be a third of what the other RAF is. So why did this code as 0? Well, it wasn't specific enough. Even though you went out to 3 digits, you have to use 4 with this. Why? Because you have to document the 4th digit, 1 being right eye, 2 being left eye, 3 being both eyes. Same thing with macular degeneration. You said the right eye, you got very specific, but you did not comment on active or non-active neovascularization, which is that 4th digit. CHF, I'm going to show you a slide on this. Besides I50.1 and I50.9, you never use just 1 digit. If you do, you're going to get a RAF of 0. Obesity, you do not get any credit for, but BMI you do for people, and that's why you always want to use these Z68 codes. So for this patient, the left side would have got you 0 RAF for your patient. On the right side, you'd have got 1.72, which is about $15,000 for that patient. Chronic kidney disease, very, very important to code. Stages, even if they're not RAFing, which stage 1, stage 2, and the unspecified stage 3, M.18.30 don't do, you always never want, you never want to use this M.8.3 now that they've differentiated stage A and stage B based on the GFR. because the N18.31, N18.32 do code. These don't code, but again, if you have them with diabetes, you get credit for the diabetes with complications. So always code to the most specific stage. Cardiology, don't use non-specific terms like coronary artery disease, atherosclerotic heart disease, angina. Angina is very important. In the HHS model, I will specify this, only unstable anginal codes, but in the CMS model, the angina, even if it's treated, remains active, is a rafhable diagnosis. So if you've got patients that are on medicines, but their angina is controlled, that still remains a diagnosis code. Angina is only resolved when it's done through a PTCA or CABG and there's no further medication or other intervention needed. Then it becomes inactive. Acute MI, you can only code it for the first 4 weeks. Otherwise, it becomes history of. So you have to make sure you change that diagnosis code after 4 weeks. So again, showing you these different things. The angina, the I-20.9, it RAFs only in CMS. It does not RAF in HHS. The unstable angina RAFs in both. And the angina with spasm, I-20.1, will RAF only in CMS. So again, even if it's asymptomatic on pharmacological treatment, still continue to code. Code these chronic cardiovascular conditions, whether symptomatic or asymptomatic. So if you have AFib, it's still an arrhythmia as long as they're on a pharmacological treatment or there's some sort of intervention going on. Congestive heart failure is always chronic after a diagnosis. So once it's diagnosed, whether it's compensated or not, you always want to include that document, and you document it as treated and compensated or uncompensated. Again, I wanted to show you this on the CHF. Do not use any of these codes. You have to go out to the more specific digits for the 2, 3, and 4 and the 1.8 categories, but the other categories all will RAF if you use those codes more specifically. For the pediatricians, you want to make sure you do the congenital defects because they do RAF, and these are the examples of those. Remember, once in arrhythmia, always in arrhythmia, unless permanently corrected without ongoing pharmacological or other intervention. So all of these arrhythmias are going to code, but you have to, or RAF, but you have to code them correctly. You get no RAF for a PVC, palpitation, tachycardia, bradycardia, or dysarrhythmia. Again, just some examples of no RAF versus RAF. AAA, you're going to get RAF for, but if you just say atherosclerotic disease of a coronary artery, you're not going to. Aortic atherosclerosis will get a RAF, but atherosclerosis of a renal artery does not. So some of these you have to remember, you just have to remember, but for the most part, just be as specific and RAF appropriately. Pulmonary, this is a little bit confusing. The adults for CMS, asthma does not RAF. Only these codes will RAF. But having said that, it does RAF for the HSS model. So again, you have to be specific. The codes in the red do not RAF. Codes in the green RAF. So when you have asthma, make sure you take it out to the most specific diagnosis code. And again, always include it. One, even in CMS where it does not RAF, it does RX RAF for drugs. But two, you never know, the commercial payers and some of the other models are going to use this, so always code this. Again, this just shows the RAF in the HHS model, the different diagnoses. They've split the category. This is the only one I think they really split into a -1 and -2. -1 being the, there's severity, and then there's a less severe. So -1 is the more severe, -0.2 is the less severe. Depression, very common mistake is we don't document things appropriately. You have to use these descriptor terms, the mania, depression, single or recurrent, use specific mental disorder terminology. If you don't use descriptor terms such as major or recurrent, then you have to use F32.9, which does not RAF. And let me show you that. So you got a major depressive order, severe without a psychotic episode, F32.2, it does RAF. With psychotic episode, you get the same RAF. But if you use any of these coding diagnoses, F32.8, other episodes, no RAF. Major depressive order, unspecified, no RAF. Again, recurrence versus single episodes. they both are going to RAF. You want to make sure you use the appropriate codes, but you do not want to use the non-specific codes. If it's in remission, it will still RAF. Again, you have to use the right codes though. The best way for depression is probably to use the PHQ-9 score. Again, in HHS, only the severe depression RAFs. In the CMS, all of the codes except for the F32.8 and F32.9, the non-specific and other codes. So even the mild and moderate code. But again, this chart will give you that kind of breakdown of what code you should use, and then the definition of partial remission, full remission, and when you use those codes. So it's a good thing to refer to when you're doing these. But again, you should document the PHQ-9 score on the chart. Dependence versus abuse. Dependence is manifested by 3 of the following: tolerance, withdrawal, increased usage over a longer period than intended, desire or unsuccessful effort to cut down, excessive time spent in activities to obtain the substance, continued use despite doctor advice. So if they have 3 of these, they're dependent. Dependent gets RAF, abuse does not get RAF. So these are showing you all those differences when you use the dependence code versus the abuse code or in remission, okay? But dependence, again, dependence or remission, those codes are going to RAF as long as you differentiate that they are dependent on this. Malnutrition, very limited use, very underreported. If someone's lost 5% in 3 months or 10% in 6 months, you can use the E46 code. The BMI less than 17.9 and the low albumin is also a way to use that, or these combinations, they have a lower BMI and an albumin less than 3.5. All of these are going to RAF. Of course, your eating disorders are going to RAF too, so you want to make sure you document those correctly. Coding of strokes. Strokes are an acute event, and you can only code them when they happen in the presence of you. Otherwise, they become a history of strokes. The only codes that are going to RAF are your late effects, your hemiplegia, your monoplegia. You've got aphasia, dysarthria, something that's a late effect of a stroke. That is going to RAF, and that's why you want to make sure that you use those appropriate codes. Every year, you've got to recode seizures. Even though the patient may be controlled, you want to make sure you do that. Showing some differences between the CMS model here and the HHS model. Again, Alzheimer's is not going to RAF in the HHS. So again, we're dealing with younger patients. It is going to RAF in all the CMS models. MS is going to RAF in both of them. Parkinson's is going to RAF in both of them. I think there's going to be some changes coming up here too on this for the HSS model. Again, pediatricians, make sure you do all the congenital malformations. For the seizures, you do get RAF for the febrile seizures, complex febrile seizure, post-traumatic seizure, unspecified convulsions. Oncology, very much misinterpreted on the charts when we do the reviews. Definitive treatment means surgery, chemotherapy, and other radiation therapy aimed at eradicating the malignancy. So that's definitive treatment. Patients who do not receive a definitive treatment for their malignancy continue to be coded for the malignancy diagnosis. So those that refuse some of these treatments and want to just live with their cancer, you've got to code them as active. Anybody that's on adjuvant therapy for like breast and prostate, those are considered active disease. The ones that aren't active are the ones under surveillance. They've completed therapy. Once that happens, you can only code personal history of cancer. So once they're cleared for their breast cancer and they're no longer treated, they're just under surveillance. Even for reoccurrence, this is surveillance. You have to do personal history. Metastatic disease, as I will tell you, this is the most important. This code will trump all the other diagnoses. So once you have metastatic disease, you get a much higher risk score, and your other diagnoses, you still code them, but they are trumped by the metastatic disease. And just to show you that, you could have all 10 of these different types of cancers. The only one that's going to risk score is going to be the one that's spread to the bone. And again, this is in the CMS system, as I showed you. It's 22.6 or almost 10 times the risk score for the HSS for just having a primary tumor in the breast, colon, and prostate. So again, just as that example, if you have breast cancer, this again, the HHS model, you're going to get a RAF of 2.64. That breast cancer is spread to the lymph nodes. Well, guess what? That diagnosis is still there, but it's overridden by the C77.8 where it's spread to the lymph nodes. Now you get a RAF score of 22.6. 0.979. So any of the C77, C78, C79 metastatic codes are going to overrule the other codes, but you always want to include both of them. Just to show you some differences of what you do get a RAF score and don't get a RAF score: unstable angina versus chest pain, Parkinson's versus a tremor, chronic bronchitis versus a chronic cough, major depression single episode severe versus depression, CKD stage 4 versus renal insufficiency, like say AFib versus arrhythmia, opioid dependence versus long-term opioid treatment, dependence with episodes versus alcohol dependence that's acute, and it's not abuse. And then, again, remember, the code that's appropriate here is the F20.10. That's the one where their dependence. This is more the alcohol without dependence. And then BMIs, remember, are going to code where the weight loss ones aren't. And then Alzheimer's is going to code versus memory loss. Again, just to show you an example of some things here that need to be to show you what happens in an MA plan if you don't code correctly. Where if you code this patient correctly, you're going to see about $17,000 attributed to that patient, whereas if you don't, you could receive only about $5,000. So again, submit the diagnosis codes for every condition you evaluate at each office visit and the appropriate documentation, the highest specificity.